I'm going to be talking about prevention of HPV-related cancers in people living with HIV. That's not just anal cancer, that's cervical cancer too, and oropharyngeal cancer. And firstly, some disclosures. I've done some work on the HPV vaccine, and I'm a board member of several companies that are involved in developing new HPV therapeutics. So what I'd like to do with you all today is just talk about the scope of the problem in people living with HIV, focusing on the 3 cancers listed here because these are the most important from a numeric point of view, and then talk about how to prevent them. And that means primary prevention in the form of vaccination and secondary prevention in the form of looking for precancer lesions and removing them before we can progress to cancer. So just a reminder that, usually when people think of HPV-related disease, cervical cancer comes to mind, and that's appropriate because it is by far the most common of the cancers associated with HPV and is by far the biggest source of morbidity and mortality. But men are also affected by HPV in numerous ways. It is a sexually transmitted infection, so men can pass it back and forth between men and women, or men and men, and women and women. And also men themselves are affected by HPV, particularly in the anal area and the oropharynx. So you can see, for example, that head and neck cancer is predominantly a male disease, at least the HPV-associated version. And anal cancer is about equally divided between men and women. These are in the general population, but you'll see that the numbers are quite different in certain subsegments of the population, notably people living with HIV. So why am I focusing on these 3 cancers in today's presentation? That's because these are the ones associated with the highest standardized incidence ratios in people living with HIV compared with the general population. Interestingly, anal cancer has the highest standardized incidence ratio, and that's largely because it is a rarer cancer in the general population than cervical cancer. But even cervical cancer, which is pretty well controlled in this country, not completely, but pretty well controlled because we have pretty strong cervical pap smear screening system. Cervical cancer does occur in the United States, largely in groups such as people living with HIV who have diminished access to these services compared with many others in the population. Here, the standardized incidence ratio is a little more than 3. But also in terms of absolute number of cases, you can see that anal cancer is the most important of the 3. Again, it's a little bit comparing apples to oranges because at the moment we don't have routine screening systems in place for anal cancer, whereas for cervical cancer, there are pretty good screening systems, and some groups of women living with HIV are especially closely screened. And then you can see that oropharyngeal cancer is associated with a statistically significant increased SIR. So I'm going to go through each of these in turn, talking at various lengths because much of the information, at least on cervical cancer and oropharyngeal cancer, is either not all that new or limited. Anal cancer, I think, is where most of the new information is. Also happens to be one of my particular areas of interest. So I'll be talking probably a little bit more about that. But just a reminder, as far as cervical cancer overall, although it's pretty well controlled in the US, it is largely a disease of the Southern Hemisphere, countries that have lower socioeconomic status and levels of development and less well-developed screening systems. So the countries, in Sub-Saharan Africa, India, South America, Latin America, are the ones that have the highest incidence of cervical cancer at the moment. And unfortunately, this is also the areas that are most affected by HIV. I don't think it's a coincidence because many of the same societal constrictions that lead to poor cervical cancer control also lead to poor HIV control. Many of the same risk factors for getting the 2 viruses coexist. So you can see, for example, here's that same map shrunk to show you where cervical cancer is. And here you can see where HIV incidences are the highest. And lo and behold, there's almost complete overlap between these 2 viruses. So it also was not surprising that cervical cancer was one of the first manifestations recognized of HIV infection in women and became one of the AIDS-defining cancers, along with Kaposi sarcoma and non-Hodgkin's lymphoma. So even though anal cancer is basically the same disease as cervical cancer, it is not considered an AIDS-defining cancer. I think that is more for political reasons rather than scientific reasons to some extent. So the classic AIDS-defining cancers, the ones that apart from CD4 level give you a diagnosis of AIDS, are one of those three cancers. So here's an interesting thing about cervical cancer. Even before we were doing a lot of vaccination, the incidence of cervical cancer was actually declining in most countries. You can see these rates coming down in many of these countries. So it obviously wasn't the vaccine, because that's only starting now to have its effects. And it certainly wasn't because we were doing better pap smear screening. It's not entirely clear why these rates are going down. On the other hand, so that's the good news. The bad news is that in terms of the absolute number of cases of cancer, they're going up. Incidence coming down, number of cases going up. What's going on? And the answer is changing demographics. Cervical cancer typically occurs in women age 40 and older, and many of the countries where cervical cancer is most common are young populations, but they too are getting older. And so we're starting to see changes in the population distribution, such that a higher proportion of these populations are now entering the age at which cervical cancer becomes more common. So if you look at estimates for number of cases of cervical cancer, in 2012, for example, it was estimated that there would be a little more than 525,000 or so cases cervical cancer worldwide. But by 2035, that would be up to 756,000, where the blue difference actually is that demographic effect that I was referring to. So the world's population getting older, or at least a higher number of susceptible women entering that age at which cervical cancer starts to increase in incidence, is the main explanation for that. What that means is that if we want to achieve the cervical cancer elimination goals of the World Health Organization, we have to work really hard, not only at vaccination, but also at screening and also treatment. Now, there's another problem when it comes to people living with HIV, which is they too, I mean, it's not a problem, it's a blessing. They're living into older ages because of antiretroviral therapy. So just by that reason alone, they're at increased risk. But it is also true that there are additional biological reasons that people living with HIV may be at increased risk. And that is that there's some suggestions that PLWH age prematurely. There are several illnesses that are associated with advanced age that are more common amongst people living with HIV. Some people think it may have to do with the longstanding effect of HIV. Some think it may be longstanding antiretroviral therapy. It's not entirely clear, but you see more neurocognitive decline, more cardiovascular disease, and a number of cancers. So people living with HIV are going to be at increased risk of these cancers a priori, but also, again, going forward, potentially as a function of age, either chronologically or biologically. If you look overall worldwide at the relationship between cervical cancer and HIV, it's estimated that women living with HIV have roughly a 6-fold increase in the incidence of cervical cancer compared with the general population. And it's estimated that about 5% of all cervical cancer cases are found in women living with HIV. So that's a pretty high number if you consider the overall prevalence and incidence of HIV in the world's population of women. And as I mentioned before, a way high number of these proportionally are in women living in sub-Saharan Africa. Now, what about anal cancer? Anal cancer is an interesting disease. It's not gotten a lot of attention compared with cervical cancer for good reason, which is that historically it's been a lot more rare than cervical cancer. But one of the things that makes it interesting is that unlike cervical cancer, where I showed you those declining incidences, anal cancer is going up, and it has been. since the 1970s in the general population, in both women, shown here in pink, and in men, shown here in blue, by about anywhere between 1% and 3% per year. We think this may reflect changes in sexual practices that have occurred in the population since the 70s. It's not entirely clear what's going on, but it is true that, number one, anal cancer is more common in women than men overall. And we tend to conflate, to some degree, anal cancer with both HIV and with men who have sex with men. And the other thing is that, unlike cervical cancer, the risk of anal cancer is not evenly distributed in the population. So the other interesting part of this disease is, although it's increasing generally, it is very unacceptably common in certain risk groups. When we look actually at those risk groups in the next slide, you'll see that they tend to be people who are often sort of more marginalized. But now, with the increasing incidence of anal cancer in the general population, as I just showed you, and the declining incidence of cervical cancer, it is now the case, for instance, that amongst white women in the general US population, 65 and older, 65 to 74, or even older than 75, that anal cancer is now more common than cervical cancer. So we can say it's a disease of specific risk groups, and it is, but I think we need to understand that this is now at least as common a cancer in certain populations that would be considered more mainstream. And in Australia, for example, overall, where they do a very good job of cervical cancer control in the general population, anal cancer is more common in women than cervical cancer. So I was alluding to the fact that certain risk groups exist, and they're shown very nicely summarized in this meta-analysis by Gary Clifford's group. And what they show is the risk scale as defined by incidence per 100,000. And you can see if you divide it into males and females and immunocompromised people with immunocompromise for reasons other than HIV, that far and away the biggest risk is in people living with HIV who are men who have sex with men. And if you look, you'll see that that risk also increases quite dramatically as a function of age for the reasons that I mentioned before. The risk is still high, even in men less than the age of 30 when they're living with HIV and having sex with men. And also a rather large group who are at unacceptably high risk are MSM who don't have HIV infection. The other point about HIV, again, if you compare it to sort of more general population numbers shown here at the bottom in green and teal, is that it doesn't really matter that much how you got HIV or what your risk group is, because men who don't have sex with men are at increased risk of anal cancer also, again, more so amongst the older ones, as are women. So with a rate of about 30 or so per 100,000 amongst women living with HIV, anal cancer is a lot more common than cervical cancer in the United States amongst women living with HIV. Again, a combination of lack of screening to this point for anal cancer and relatively good surveillance for many women living with HIV in different US locations. You don't have to have HIV. Having other HPV-related cancers is another important risk factor. Not surprisingly, vulvar cancer is way up there. The vulva is the next door neighbor of the anus, and there's actually no border that says, here's the vulva, here's the anus. And we have good evidence to suggest that in addition to anal intercourse as a risk for getting HPV, women can also get spread from their anterior genitalia. It can spread from the cervix, it can spread from the vulva. So women who have a history of vulvar cancer or precancer are at high risk of anal cancer, and even women with a history of cervical cancer and potentially cervical HISIL. So this is also a very important group. The risk isn't quite as high as in MSM living with HIV, but it's a very large group. And then we must forget that other causes of immune suppression are also important. One of the most common here in the US would be solid organ transplant and iatrogenic immunosuppression to prevent graft rejection. And here, interestingly, it's not so much a function of age, though age is conflated with this, but rather the number of years of immune suppression. So the risk of cancer goes up the longer you are post-transplant, basically meaning the number of years that you've had at least some degree of immune suppression to prevent rejection of that graft. So these are the main groups that we need to think about if we're going to start talking about screening. And I guess, it's good news, obviously, that we don't think we're going to need to screen everybody, that we can focus our efforts on these groups. There are people who will fall through the cracks. A lot of the women who I see in my clinic, for example, are people who don't fit any of these categories. The classic story is a woman who may have noticed some anal bleeding, goes to see the proctologist, who says, oh, it's hemorrhoids, treats her for hemorrhoids, the bleeding doesn't go away. Eventually she comes back and that cancer is diagnosed. It happens. But again, if we're going to have to prioritize, this gives us a pretty good guidepost for where to start. So where does anal cancer sit in the cancer pantheon of HIV? It's changed a lot, actually, over time. Remember, cervical cancer was an AIDS-defining cancer. And as ART came onto the scene, a lot of different things happened. KS and non-Hodgkin's lymphoma declined in incidence as ART helped to control those. But anal cancer actually got more common. Cervical cancer didn't so much, again, because we have pretty good surveillance for that. But anal cancer is kind of a natural history experiment. Here's what happens if you don't screen for these cancers. Anal cancer became more common. And the reason is because the immune system, as it reconstitutes, doesn't help that much against HPV. It helps some, but not that much. And if you balance that with the better survival and the longer term risk because of ART, the net effect was an increased incidence of anal cancer. Over time, there's been some degree of control of anal cancer, but not all that much. And it is now and is projected to remain the fourth most common cancer in people living with HIV, where the other three are actually, particularly prostate and lung, are diseases of aging rather than HIV per se. I'm going to say a little bit about oropharyngeal cancer here. It's complicated because unlike anal and cervical cancer, the attributable risk to HPV varies depending on where you are in the world. A high proportion of them are associated with HPV here in the US, less so in other countries such as India. But the risk of oropharyngeal cancer here is shown on these maps, does vary considerably between men and women. Men here are on the left, where it seems to be predominantly in parts of Northern Europe, whereas in women, it's more evenly distributed, oddly enough, in Russia and Brazil. Now, like I showed you with cervical and anal cancer, with the decline in the incidence of cervical cancer, the incidence of oropharyngeal cancer going up in certain populations. Oropharyngeal cancer is more common than cervical cancer is in women. And overall, in the general population, they're expected to cross very, very soon. This is in men, but in the overall population, that will be the case pretty soon as well. And like I said, here in the US, HPV is a very important cause of those cancers, and those are increasing compared with the older population that has a kind of a parallel epidemiology of oropharyngeal cancer, which is more related to smoking and alcohol use, probably leading to P53 mutations, which is similar to what happens in the HPV-related cancers, though it's not a mutation, it's inactivation of P53 by the E6 protein of HPV. So again, the HPV version going up, since we're having lower rates of smoking in the general population, the older non-HPV associated cancers coming down. So question is, what should we do? I think we have a great opportunity here. That was what International HPV Awareness Day was all about, because unlike some of the other cancers like lung cancer, there's not a lot to do other than trying to get people to stop smoking. You can do some screening with spiral CTs, et cetera, but there's not a lot of prevention opportunities. So HPV presents us with two opportunities for prevention. And we think that if they were implemented fully, we could truly get rid of HPV-related cancer. That's what the WHO campaign for cervical cancer is all about. And they're not as focused on anal cancer as I am, or even oropharyngeal cancer. But the good news is that everything that we're proposing for cervical cancer prevention also should work for the HPV-related cancers at these other anatomic locations. So again, we're talking about primary prevention in the form of vaccination, or secondary prevention to screen for high-grade lesions. I'm not going to spend a lot of time on the vaccines because everybody's familiar with them. The only vaccine that's currently available right now in the US is the non-valent vaccine, which has type 6 and 11 in it to prevent warts, type 16 and 18 to prevent the majority of cancers, and then an additional 5 types to prevent another 10% or so of cancer. So if you add up the 7 high-risk HPV types in the vaccine, that comes to a little bit more than 90% of the known causes of cancer worldwide. So the big news here is that we projected that there would be a reduction in cervical cancer, but eventually, and the reason is because normally it takes decades from the time of initial vaccination, or the age of initial vaccination, which is around the time of sexual debut, to the time a cervical cancer would normally show up in the absence of that vaccination. So the reduction would be expected to take quite a long time. The proxy for that the FDA has accepted, that we all accept pretty much, is high-grade disease, since we believe that to get to a cancer, you have to have high-grade disease. And if you can prevent high-grade disease, you can prevent cancer. So the vaccine trials were aimed at showing reduction in incident high-grade disease and in persistent high-risk HPV infection, which is the main risk factor. But now, for the first time in the last year or so, we are starting to see the projected increase, reduction rather, in cervical cancer. This was one example where the rates of cancer reduction were the highest when the girls were vaccinated the youngest. And that's presumably because, for example, compared with young women who were vaccinated 16 to 18 years, some of them acquired HPV between 12 to 13 years when they could have been vaccinated, and the age at which they were actually vaccinated. So some of them still got HPV infection, and those in a small proportion did lead to cancer. So the Advisory Committee on Immunization Practices does recommend routine vaccination for boys and girls, 2 injections for boys and girls when they're starting at the age of 14 or less, 3 at 0, 1 to 2, and 6 months if you're 15 or older. You can begin as early as 9. The idea is to try and vaccinate people before they have sex, because the vaccine is preventive. It won't help you if you've already been exposed to that HPV type. And importantly for this discussion, people living with HIV are still required to have 3 vaccinations. And then you can have a vaccine up to age 45 after a conversation with the provider and between the provider and the patient. Very recently, like a week ago, the United Kingdom has a task force that actually recommended going to 1 dose for both males and females in the United Kingdom under the age of 14. I think it's a little bit controversial. There's a lot of data to suggest that 1 dose might work, but there's still data that we're waiting to have come in, and we don't know how long the protection is going to last compared with 2 or 3 doses. But people feel that it's safe to do in a place like the UK because they have a really good screening system as a kind of a backstop. So if it fails, they should still be able to catch people before they progress to cancer. So we'll be reading and hearing a whole lot more about that, I think, in the coming months. So there's that UK Joint Committee on Vaccination. We spent quite a lot of time talking about that on our International HPV Awareness Day campaign events. The information is shown here on this website if people want to go and see what the committee was thinking. So what about vaccinating people living with HIV? I mentioned they should have 3 doses, but there are questions still, even in this population. There's questions about the safety of vaccination. If you vaccinate somebody, you're going to elicit immune response. Are you going to somehow throw HIV viral load off? Are you going to cause a reduction in CD4 level? I think we can quite confidently say no to both of those at this point. There are questions about the effect of HIV-related immune suppression on the immune response, namely the titers that we generate against HPV. And here we do consistently see a reduction in titers compared with people who are not immunocompromised. And that tends to be more pronounced in people with lower CD4s, either current or nadir, or who have a higher HIV viral load. But the key point here is that those titers are still pretty good and probably above what we need for protection, because now there are more and more data on efficacy. It's difficult to do an efficacy study with the vaccines because the incidence of disease is pretty low. The study needs to be huge. That's why only the government or big wealthy companies can do them. So there have been limited efficacy studies of the vaccine in people living with HIV. We actually did one in the AIDS Malignancy Consortium, which I'll describe in a little bit. And then the other issue is, even if the vaccine is safe and effective, can you get it to people who need it? There are a lot of issues with access to the vaccine in a variety of settings. Either they can't afford it, low socioeconomic status, or life challenges that prevent people from being able to go in and get vaccinated. One thing that I thought might be fun to show you is how different groups compare with respect to titers. Now, these are various studies that I pulled together. They're old enough that this is with the quadrivalent vaccine, but I want to just focus on the HPV-16 titers because that's the most important HPV type. And the point here is that, for HIV negative people, the younger you are, the better your immune response, the higher the titers. But interestingly, when you have HIV, those titers are lower, as I mentioned before. The one exception to the HIV negative comment that I made is MSM, because in a study that we did to get the vaccine approved for prevention of anal HPV infection, it was interesting that the MSM who were HIV negative actually had titers that were similar to people who had HIV. And so the lowish titers tracked more with being MSM than HIV positivity or negativity. This has actually been seen before with some other vaccines, including hepatitis B. I don't think we really understand why that's the case. So here, if you're going to vaccinate people with HIV, particularly MSM, age is critical because the older you are, the more sexual exposure you've had, and the more HPV exposure you've had, and the less efficacy you can expect from the vaccine. So it wasn't surprising, for instance, that in a study done of vaccination amongst MSM 27 years or older in the ACTG, that there was no efficacy against HPV infection or anal H cells shown. So we thought, if we're going to give this vaccine a chance, let's go younger and try to vaccinate people 18 to 26 years. Ideally, you want people vaccinated even younger. But for the reasons that I mentioned, a lot of people living with HIV aren't getting vaccinated. So we said, let's do 18 to 26 years. This was AMC 072. And we learned a lot of very interesting and somewhat alarming things. The first was that even though most of the men were in their early 20s, already more than a third of them had high-grade disease at screening. So they're getting HPV infected early, and they're developing H cell quickly. We also looked for the proportion of people who are naive to those HPV types in the vaccine as a way of figuring out who is going to benefit from it or not. And this 47 is the proportion who are naive to HPV-16. So that means that already more than half had HPV-16 infection. and wouldn't benefit from the vaccine for protection against that HPV type. But you can be a half full or half empty sort of a person and say, okay, well, we can still protect about half of them. So these are the proportions for 6, 11, 16, and 18 that could expect to benefit from vaccination. It really is worth it to vaccinate them, though it'd be even better to vaccinate them at a younger age. Also important, though, was because the incidence of disease is so high in these populations, we were able to actually show efficacy in a relatively small group. So we did see no cases of incident anal HSIL in people who are naive to those HPV types. If they'd already been exposed, they did have incident anal HSIL. So we do expect the vaccine to be efficacious, provided the individuals being vaccinated did not previously meet that HPV type. When you look at the titers, again, these have a very typical pattern. This is 6, 11, 16, and 18. They peak about a month after the third injection, and then they decline and they plateau. So it is not clear what the cutoff is yet, because the vaccine failure rate in the overall population is so low, we still don't know what the protective titer is, but this is almost certainly above it. And the other interesting thing was that for people who weren't naive, we do see substantially higher titers indicating the presence of a memory response. So in this sense, apart from the absolute levels of the titers, the patterns are very similar to what we see in people living with HIV. So the bottom line for this group is vaccinate everybody up to the age of 26 and vaccinate as early as possible prior to sexual debut. You need 3-dose regimen yet? We're not even talking about 2, still it's 3. Consider vaccinating up to age 45. I think that's a little more iffy. And certainly the benefits of vaccinating after age 45 are certainly unclear. What I tell a patient, say, who's in his or her early 30s is, the vaccine is safe. It may protect you against HPV types that you haven't yet been exposed to, but check to make sure that your insurance carrier covers it, because it can be costly and not everybody can afford it. So the next thing is secondary prevention. And here I'm going to zip over screening for cervical cancer, because the guidelines here haven't really changed very much, but it's all based on this model of going from HPV infection here to high-grade disease, and again, removing this lesion before this event happens, which is progression to invasive cancer. And you'll notice that I have both CIN and AIN here because histologically they're very, very similar. The guidelines are a little bit different for women living with HIV compared to those who don't have HIV, but they're all pretty unchanging in the last few years and available on the ASCCP website and other entities like ACOG. The main principle here is you can use HPV as a screen, you can use cytology or a combo, but just like with women who don't have HIV, we don't recommend using HPV testing as a screen when you're under 30 because the prevalence of HPV is so high. What about screening for oropharyngeal cancer? Well, there is no screening test for oropharyngeal cancer. All we can say right now is to recommend regular, thorough oral examinations by a dental professional, which includes a careful palpation of the head and neck for lumps, because oropharyngeal cancer can spread quite quickly to lymph nodes. There's a lot of interesting research going on. Some people think that DNA testing of saliva might be useful. There's some evidence to suggest that HPV E6 seropositivity might be a marker. Even serum HPV DNA is a marker for cancer. None of these are ready for prime time, and maybe we'll have something in the next few years, but it's hard to know at this point. So I'm just going to finish off by talking about screening for anal cancer. The cervical model, as you know, is to look for and remove those high-grade lesions. So since I've been saying over and over again that anal and cervical cancer are so similar, then you might ask yourself, well, why don't we just go ahead and do the same things for anal cancer? And in fact, that's kind of what we've done. in the anchor clinic that Sandeep told you about. We've been doing this for about 30 years, but it is not yet standard care, and that's had a significant impact on our ability to implement it in the risk groups that I've shown you. And the reason that it's not standard care is because we don't have evidence that it works. Not that it doesn't work, it's that the study hadn't been done to show that it works. And remember, I said that to do an efficacy study for vaccination, you need a very large group of people because the incidence of disease is relatively low. And the same is true for a study like this. A lot of people get HPV infection. A lot of people even get precancer, but a relatively small proportion of those individuals get cancer. So if you want to do a cancer prevention study, you need a pretty sizable number of people. So you may ask, why might we even doubt that it'll work? And there are actually very legitimate reasons to ask that question. One is that the groups who are at highest risk, the ones we're most interested in helping, are people who by definition are also the most challenging to treat. They have the largest lesions, they have the most multifocal disease. These are the lesions that fail the most commonly when you're treating cervical disease to prevent cervical cancer. So this is a tough group. And if it's going to fail, it's going to fail in this group. Also, high resolution anoscopy, which is a cervical colposcopy equivalent to identify those high-grade lesions, is a really challenging technique procedure to do. It takes a long time to get really good at it. And there's lots of reasons why you might miss a lesion. The anus has a lot of geography in it that might prevent you from seeing something that isn't as challenging in the cervix. So clinicians might miss lesions, and if they don't see them, then they can't treat them. Because unlike in the cervix, where you can remove a whole chunk of cervical tissue, like with a LEEP, you can't do that in the anus. So we have to be very choosy about where we stick our treatment probes, for instance, if we're doing electrocautery. And since you can't treat something if you don't see it, there's always the possibility that you might not treat a lesion. And you might even inadequately treat it if you see it because they're so large. And then the other is that new lesions often arise. I call that anal whack-a-mole. You find a lesion somewhere on one side of the anus, get rid of it, 6 months later, there's a whopping one on the other side. Very challenging group. So we did the study. It's called the Anchor study, as Sandeep told you. And there were 4 aims. The aim that was most important to this was to determine whether treating anal HSIL is in fact effective at reducing the incidence of anal cancer. The second is to determine the safety of the treatments that we use. The third is to measure our impact on quality of life. Supposing we can prevent anal cancer, but in the process of doing that, we make everybody really miserable, and they're so miserable that they figure they'll take their chances with the cancer. So we developed an instrument called the Anchor Health-Related Symptom Index because there were no validated instruments available for this disease in this population to look at quality of life. And then very importantly, we wanted to create a biobank of specimens that would allow us to answer some really important and unique questions, namely what happens from HSIL to cancer. A question you can't really answer systematically anywhere in any other body part at this point. You can't do it in the cervix because it's standard of care to treat cervical high grade, so you don't want to follow those. You can't do it in the oropharynx because we don't have an easy time finding oral HSIL or oropharyngeal HSIL. So we felt that this was one of our last chances to collect a well-annotated set of specimens from people who are shown to have HSIL, some of whom progress to cancer, and try and figure out what are the host and viral factors in that process, and also develop biomarkers, because as you'll see, about half of our population has HSIL, and in the absence of a biomarker that tells us this is a person who needs immediate treatment, this person can be followed, we're stuck with treating an enormous number of people. So the study schema is shown here. This paper isn't yet published. It's currently under review. And basically, we took the highest risk group of people, who are people living with HIV over the age of 35, and did high-resolution anoscopy on all of them. If they were found to have biopsy-proven high SIL, then and they met the other enrollment criteria, they were randomized 1-to-1 to what we called active monitoring or treatment. They were treated on the same day they were randomized. I'll tell you a little bit more about that. If they didn't have HSIL or they weren't otherwise eligible, they were not in the study, or if they had cancer found at screening, also they weren't enrolled in the study, they were referred for immediate therapy. So for those who were randomized, we followed them and then counted up the number of cases of cancer in both arms. So as I mentioned, you need to have a pretty big study to do this, and we determined that we needed to actually enroll 5,058 people with biopsy-proven high-grade disease to be able to answer our question in a reasonable amount of time, and projected that we would need to actually screen more than 17,000 people. We were powered to detect the difference between 50 and 200 per 100,000 person years in the two arms at a P of 0.05 with power of 0.9. And this was an event-driven analysis where the primary outcome was time to cancer. I mentioned that we thought we would need a total of more than 5,000 people, where our projected number of cases of cancer was 31. So big study, we needed to do it at a lot of locations. We actually at different times had 25 sites around the country seeing participants, including Puerto Rico. So after our participants provided informed consent, we took blood from them, we took swabs for cytology and other biobank specimens, did HRA and did the biopsies. And if the biopsy showed HSIL and they were eligible, they were randomized, they then had a questionnaire to detail medical history and lifestyle information. And we stratified randomization by study site, their nadir CD4 count less than or greater than 200, and lesion size at randomization more than or less than 50% of the total area of the anal canal. This is just one example, I'm not going to go through it in detail, of how people were treated. The clinicians had a choice of basically ablative treatment modalities or topical. They had to pick one of the menu that we provided them with. And based on which one they picked, they also had to follow a particular treatment algorithm. So basically we treated, for instance, with bifurcation, which is electrocautery. Many individuals, they were required to be seen within X number of months after the treatment, rebiopsied to make sure they didn't have high-grade disease, and then if they did, to get retreated, either with bifurcation again, or the clinician could change their modality of therapy. The goal, though, was for the clinician to try and treat as much HSIL as possible. So they were, if they were in the treatment arm, biopsied repeatedly to make sure they didn't have HSIL over again. They had cytology swabs, HRA every 6 months, or more often potentially, if there was concern for cancer, we saw people every 3 months, and anytime there was concern for cancer, they were biopsied. If they were in the active monitoring arm, it was the same thing. The only difference was we didn't biopsy people every 6 months because we didn't want to biopsy the lesions away. We did, though, biopsy them annually to confirm the ongoing presence of HSIL, absence of cancer, or potentially regression of disease. So here were the results. The study was actually stopped early. We didn't actually end up reaching our recruitment goal because we didn't need to. Namely, the incidence of cancer was higher than we were expecting, and we stopped the study when we reached that case count. That case count was reached when we'd screened 10,723 people living with HIV instead of the projected 17,000. We stopped screening in August, and these numbers show you the high rates of high SIL in our screening population, including women, about 46%. That's enormous. You know, if you were to, just randomly sample a group of healthy women in any US city for cervical disease, less than 1% would have cervical HSIL. So almost half of the women had HSIL in the anus. and a very high proportion of transgender individuals. We also found quite a few who had cancer at screening, 17 of them for a prevalence of 160 per 100,000. Let me put this in context. In the cervix, again, in a screened population, in the US, the incidence of cervical cancer is more like 8 per 100,000. In terms of our randomized population, we actually stopped screening when we reached 4,446, because that's when our Data and Safety Monitoring Board told us to stop the study, because in fact we had reached an efficacy endpoint. Just to give you a little bit of an idea of who these individuals were, they actually pretty reasonably mirrored the overall US HIV population. They had a mean age of 51, a median age rather. They were 17 years after HIV diagnosis. We followed them in the study for a little more than 2 years. 80% were male, 16% were female, 3.1% were transgender. We had about a third being non-Hispanic white, 42% were African-American, and about 16% were Hispanic, non-African-American, 1.3% were Asian Pacific Islander. Most using the old CDC risk groups were homosexual, 78%, 23% were heterosexual, and 8% were injection drug users. About a third of the population were smokers. I mentioned that because smoking is a risk factor for anal cancer. And actually, the overall population was under pretty good HIV control. 80% had an undetectable viral load. The CD4 count at randomization was over 600. So that is pretty good. As far as the stratification factors were concerned, about half had a low nadir CD4 count, and only 13% had really large lesions of more than 50% of the anus or perianal area. So when people were put into the treatment arm, basically almost all of them had electrocautery, mostly hyfurcation. We were not powered or designed to compare one treatment to the other. ANCHOR was a treatment strategy study, treatment versus non-treatment. But since almost everybody had hyfurcation, most of what I'm going to tell you you can infer applies to hyfurcation. Not only did almost everybody have hyfurcation, but most also only had hyfurcation. A few had treatment with additional modalities. So we notified the Data and Safety Monitoring Board when we reached 32 cases. Remember, I mentioned our target was 31. The final analysis was actually based on 30 cases, and that's because we determined that 2 were ineligible because they actually had been diagnosed with anal cancer before randomization. So of the 30 cases, 9 were in the treatment arm and 21 in the active monitoring arm, for a 57% reduction in anal cancer, which was statistically significant. And this shows you the incidences of the cancers in the 2 arms: 173 in the treatment arm and 402 per 100,000 person years in the monitoring arm. This is the Kaplan-Meier curves of the incidence here in the monitoring arm and the treatment arm. So the rates are high actually in both arms, but fortunately lower in the treatment arm compared with the monitoring arm. So based on that, the DSMB not only stopped the main study, but recommended that we offer treatment to everybody in the monitoring arm, which we're currently doing, and we're continuing to follow actually everybody probably for another few years, whether they were in the treatment or the monitoring arm, offering treatment to everybody who wants it. The other thing I should tell you is that the safety was really excellent in the study. We had some deaths in the study, but none of them were related to the study procedures. And of the thousands and thousands of procedures that we did, we had only 7 study-related serious adverse events in the treatment arm and 1 in the monitoring arm. You can see here the list of things that happened, but everybody recovered pretty well. So the implications of the study are that treatment of anal HSIL is effective in reducing the incidence of anal cancer. And these data should be included along with other data such as cost benefit, quality of life impact, for inclusion as standard of care as far as screening for and treating anal HSIL in people living with HIV. It also means that we still need to do more work on getting better for treating anal HSIL because the rates of breakthrough, if you will, were still too high. We need those biomarkers because we really don't want to treat more than half of the population if we can help it. And we need to optimize screening algorithms because Anchor wasn't a screening study. We did HRA on everybody, and HRA is the best technique, but it is not feasible as a screening technique in the traditional epidemiologic sense of screening. We do need to scale up enormously as far as training people to do HRA because there's a very limited number of people who are trained to do it currently. And the other thing is we talked about other risk groups. And so can we take our data and extrapolate them to these other risk groups? My personal belief is yes, we should, because if we can show efficacy in a group as tough as people living with HIV, if anything, I think our results will be even better in these other groups. That's one main point. But the other is, I don't think Anchor can ever be replicated again in any of these other groups simply because of the size and expense of doing a trial like that. So I think these are the data that we have. We're going to need to decide whether we can apply them to these other groups or not, even though they weren't directly involved in the study. And my belief is that we should. So I just want to conclude by reminding us once again of the WHO global strategy to prevent and eliminate cervical cancer completely. The goals are 90% of girls vaccinated, 70% screened, and 90% treated. And Dr. Tedros had a very nice quote about eliminating cervical cancer as a public health problem and making it a disease of the past. And I took the liberty of adding my own little quote that we can also use vaccination and screening to make all HPV-related cancers a disease of the past.